Welcome to AETCM, the emergency medicine channel. Today I'll be presenting a case of a 54-year-old male who presented to ER with complaints of headache and diplopia. On initial 10-second assessment, patient is conscious, oriented, obeying commands. Primary survey, airways patent, no gurgling sounds of stridor. Breathing wise, air entry is bilaterally equal, no added sound. Saturation of 98% on room air and respiratory rate of 20 per minute. Circulation of pulse rate 98 per minute, BP of 170 or 100 millimeters of mercury. Capillary refilling time of 2 seconds. Disability wise, GCS of E4, V5, M6. Pupils equal and reacting to light 2 mm equal. Moving all four limbs and GRBS of 132 mg per deciliter. Exposure wise, temperature of 97 degree Fahrenheit, pain score of 7 out of 10. Injection PCM 1 gram IV stat was given. Adjuncts of primary survey, we had done ECG which showed normal sinus rhythm. And secondary survey, 54-year-old male came with complaints of bilateral occipital region headache. Gradual onset progressively increased over these 2 weeks associated with double vision. He was having horizontal suppression of the objects whatever he sees, and it improves on closing one eye. He had a history of fall 3 weeks back, and he had also trauma to back of head. As he says, he had hit the headboard of his bed. And there is also history of associated alcohol intake also during those episodes of fall. No other history of fall he has mentioned, and no any other history of vomiting, loss of consciousness, seizures, ptosis, ENT bleed, any chest pain, abdominal pain or fever. No allergy to any medications, no past history, and not on any medications.
Okay. Fine. So
54-year-old.
54-year-old male with headache and diplopia. So headache and diplopia, what are the differential diagnoses that you need to consider in the ED? Just take away the trauma part. So
okay, first we will have to differentiate if it is a monocular diplopia or a binocular diplopia is complaining of.
Okay.
So if it is a monocular diplopia, it will be mostly ophthalmological causes we have to rule out, and that can also be a cause for the headache. As in any refractory errors or any cataract and all involvement can be there. Then if it is a binocular diplopia, then we'll have to rule out other cranial nerve palsies or any cerebellar cause for the diplopia.
What are the common causes for a headache with diplopia? Most common causes that you can get a patient in emergency room. It's migraine. Migraine is one of the most common causes. You'll have, what are the ocular variants of migraine? What are the ocular variants that migraine can come up with? Ophthalmoplegic migraine. So that is a classical. They can come with diplopia. Then they can have color vision, sudden loss of color vision. They can have come with sudden loss of color vision. They can come with like amaurosis. Suddenly they are losing their vision and they are coming to the ED. After some time, they might not having even headache also. So this can be a preceding of your headache. So before they start developing headache, they can have these symptoms. So these are the most common reason why they present to the EDs. What the most common one? But you need to look in for the other causes. So can you tell me what all things can cause a diplopia? What are the reason behind the diplopia? From periphery to the brainstem, wherever it is originating. So what could be the reasons for diplopia?
As I said already, the monocular causes, local causes for...
Local causes, okay, direct trauma, direct injury to the nerves also then.
Then can be cranial nerve palsies.
Cranial nerve palsies. So causes for cranial nerve palsies. What are the common causes for cranial nerve palsies?
It can be due to any direct SOL or any mass compressing the nerves, or any due to any edema in the brain, cerebral edema, or any mass effect compressing the nerves, or due to trauma itself, injury.
Then, overall, you can have cranial nerve palsy. Any infections, you can have cranial. Herpes infections, you can have cranial. Which all other problems that can affect autoimmune pathologies, you can affect the cranial nerve. You have myeloproliferative variant of GDVS. Then, toxins, anything can affect the cranial nerve. Which toxin can affect the cranial nerve? They can complaints of diplopia, ptosis. Which
snake
toxin?
Envenomation.
Neurotoxic snake envenomation. That is any other toxin. What are the differential diagnoses? You just take the differential diagnosis of acute flaccid paralysis. You will get that. botulinum toxin. So these are all very rare, but you need to consider because snake venomation and all, especially in crate bite and all, they will just come with sudden onset of visual loss, or they will just come with weakness, and we don't know. So that is again one thing. And brainstem strokes. Brainstem strokes also that you already said. So you can have a tumor, or you can have the blood supply, or it can be a direct trauma, or it can be a toxin. That is a global issue. But why the cranial nerves are getting affected first in toxins? Not exactly the cranial nerve, the smaller muscle will start getting affected first. So that is the reason. The smaller muscle, group of muscle will start getting affected. Then slowly it will start affecting all other major, like diaphragm and all. Initially it will not get affected. Phrenic nerve is not seen initially. So later only you will be able to see. So slowly the smaller muscles, smaller nerve roots will start. So we'll start getting elicited the symptoms much more earlier. Maybe it is affecting all the cranial nerves, all the nerves together, but it is a smaller nerve and a smaller group of muscle is affected. We are able to see it very early. So that is why ptosis. Can we have in hemotoxic envenomation ptosis? Can we see hemotoxic envenomation with ptosis? Yes, Russell's Viper. Russell's Viper is notorious to cause both hemotoxic as well as neurotoxic. So ptosis, diplopia with hemotoxic, you have to think of Russell's Viper. When you have only ptosis, then and diplopia without any local envenomation, then you have to think of crate envenomation. Then you have local reaction with diplopia and ptosis and all those things. You have to think of which one? Cobra. Indian cobra, not the Indian cobra, you have to suspect. So that is a toxidrome. Just I want to discuss just our idea, because we didn't get any history of trauma initially. So we just had a patient who has come to the ED with a headache with diplopia, but here the other toxins and all, the headache is not a reason. But due to the diplopia itself, they can start developing headache, as you said before. So here our concern is whether this headache and altogether that pathology is causing the diplopia, or due to this diplopia the patient is developing headache. So that is a major difference that we need to make in here. Then you got the history that he had a fall. Now he had a fall. Now we are suspecting, okay, there is some fall. And why he should have a diplopia for a subdural hematoma or an epidural hematoma, or whatever be the subarachnoid hemorrhage? Yes, it's very common to have pupillary difference because that area can get affected. Why usually in the subdural or epidural hematoma, why they should develop?
There can be mass effect from the SDH, the size is large.
Okay, so a small SDH and all, you will not be able to get all the symptoms. So it's a larger SDH, yes, he'll be able. So we are more concerned. He has come with the history of fall now, and then he's complaining of diplopia. Maybe the size of the injury is a little bit on the higher side. Okay, so that's your initial assessment. So how will you assess for your diplopia in ED?
Initially, we will have to differentiate between whether the diplopia is seeing it as two separate, seeing one image as two, or is it just the blurring of vision. If it is blurring of vision, we have to assess regarding that blurring of vision and loss of vision, like that. If it is seeing as two images, one of images seen as two images, then you have to, next question should be, we have to close each eye and ask him if it is disappearing on closing the eyes. If it is disappearing on closing the eyes, then it is mostly a binocular diplopia. If it is not, if it is persisting, then we have to find out which eye is causing the diplopia.
Okay.
And that ophthalmological evaluation of that eye
needed to be done. Okay.
If it is binocular diplopia, then we'll have to see if it is horizontal separated images or he is having vertically separated images.
So what this patient had?
Patient had horizontal separation of image, but here on arrival, patient didn't have
any symptoms.
He didn't have symptoms.
Okay.
Earlier he said while he was outside only he was having these symptoms. Now on arrival he didn't have any symptoms.
Okay.
And if it is horizontal, we will have to further investigate regarding any third nerve palsy is there or not. And
how will you assess for third nerve palsy?
Third nerve palsy, first you have to check for any ptosis is present or not. And then we'll have to check for, except for the lateral rectus and superior oblique, rest all muscles supplied by oculomotor. So you have to check for extraocular movement with the examination. You have to check for the extraocular movement. If no squint or anything is obvious, then we can say it is normal. Oculomotor now. Then
okay.
oculomotor.
So that is where initial assessment. So you have now this patient, he don't have diplopia right now in the
he
ED.
doesn't
He
have
just had a headache and history of fall. Now whether to go ahead for an imaging, that is the next question. So somebody has come with trauma to the ED. So whom all you need to image? So you have a clear guidelines. You have the nice guidelines. You can just tell me what are the indications. Immediately, who all need CT, or later on who needs CT, or who doesn't need a CT at all.
Okay, so initially, if the patient has Jesus drop of less than 15, even after 2 hours after injury, it's an indication. Then if
No, I'm questioning the patient has come in front of you. You're telling this patient needs a CT right now. So which all patient you will say, okay, this patient needs a CT right now.
if from baseline any drop in GCS, we will have to take a CT. Then at least 2 episodes of vomiting or greater, then we'll have to take, or any seizure episodes, then we'll have to take. Then if there is any history of any loss of consciousness, we'll have to take, or any amnesia, retrograde amnesia greater than 30 minutes. He's having amnesia, then we'll have
Focal neurological deficit.
focal neural deficits. We have to take if any open skull fracture or depressed skull fracture. We have to take then any signs of basilar skull fracture. Age greater than 65 years.
We have to take. So age greater than 65, definitely you have to take. So these are the immediately you need. So that's a nice guidelines. And most importantly, you said one important thing, dangerous mechanism, and one important thing that you said regarding drugs. So you said he's not on any drugs. So anticoagulants, more than antiplatelets, anticoagulants. So these days patients are on various anticoagulants. So we have to check that history also. So depending upon that, you need to say. And few group of patients who don't have any, they are conscious oriented. Maybe later on only they need a CT, not an immediate CT. So you can go as per the updated NICE guidelines. So that's the easiest one where you can use it for evaluation of trauma. So as per the NICE guidelines, do you want to do a CT or not?
He's having a complaint of diplopia. So in that case,
definitely you can take it as a focal neurological deficit. You can take that as a focal neurological deficit, and you can proceed with an urgent CT. So what was done for him? CT.
CT brain plane was taken, which showed extraxial subdural bleed noted along bilateral cerebral convexities.
Okay.
In right side, it was around 14 millimeter. Along right and left side, it was 18 millimeters.
Okay.
And there was midline shift towards the right of 7 millimeters. So already imaging wise itself, there was indication for further surgical plan instead of non-operative management.
So again, you have a patient who is having a full score right, full GCS score right now, and you have got a CT report, and you have shifted him back from the CT. So now you said, okay, what are as an ED physician, what is your responsibilities? What are your priorities in this patient?
First of all, we have to clear in a trauma patient. First of all, you have to clear for C-spine.
C-spine, we didn't get any history initially. Later on, you got
2 weeks history, so we didn't.
So patient is sitting up in the ED, fully conscious oriented. You don't have any neck pain. So you are ruled out a cervical spine injury.
Then you have to clear the first airway, then breathing, circulation, disability.
So clearing is fine. So what is our target? That is my question.
Target. So first BP we should keep less than 160 and more than 100.
100 or 110?
100 for patients from 50 to 69 years, we have to keep it above 100. But if it is 15 to 49 years or above 70 years, we have to keep it more than 110.
I am more concerned regarding hypotension than hypertension in this group of patients, because we don't want to cerebral perfusion should not be get affected. So more than 100 for 50 to 69, and above 69 you need to keep it above 110. So that is very priority. So that you need to maintain. So for that you need to start on fluids or whatever be the reason. The next thing,
then oxygen saturation, we'll have to keep it above 90% or PaO2 above 60.
Okay, so you should avoid hypoxia. Simple
and
thing.
Then carbon dioxide, PCO2 level should be between 35 to 40.
Maintain normal level.
And then further, we should keep normal glycemia.
Normoglycemia,
So
hypo as well as hyper
should be prevented. So 80 to 180 will keep as target. Then maintain normothermy also, with the cutoff from 36 to 38.3.
So prevent secondary brain damage. So that is already there is a primary injury as in terms of subdural hematoma. So you want to prevent the secondary brain damage. That's fine. Then what are the other instructions that you want to give to the staff nurse?
We have to keep the head end elevated to about 30 degrees.
Okay, that is your first tier, second tier, third tier, and fourth tier mechanisms. So first tier you are keeping him head end elevation.
Then avoiding any neck ties or any neck compressions. And then
How frequently you want to monitor GCS in this patient?
Every 1 hour up to 24 hours, 1 to 2 hours.
Ideally, preferably, I will say in the first 6 hours, I will go with 30 minutes, preferably in the first initial hours, and then maybe hourly when the patient has come to the ED. So after that, you can GCS as well as pupillary assessment needed to be done, and when they should be alerted, when the neurosurgeon should be alerted immediately.
If we have to check in GCS wise if there is any drop in GCS,
Any drop off?
start to become drowsy, then we have to see for any drop of 2 or more.
Which one you will be more concerned? Eye response, motor, or verbal?
Eye and motor.
Eye and motor is we should be more concerned.
And if there is any pupillary asymmetry or any reactivity, less reacting and all, then we'll have to suspect further raise in ICP pressure. And
what are the drugs that you wanted to start him for? 1, 2, 3 agents. Reason and rationale for starting.
Okay, so first we'll have to see if the patient has a large SDH and all, then we'll have to start him to prevent IC pressure increase. So for that we can start on osmotic agents such as 3% saline. We can start.
Target sodium?
Target sodium we can keep it 140 to 135 to
upper the normal limit. Upper the normal limit. So 145, around 145.
45 we can keep.
Then the next thing, you want to give mannitol in this patient or not? So there has been a question, role of mannitol in head injury. You have epidural hematoma, subdural hematoma, and subarachnoid hemorrhage. So previously it was told you should not give mannitol for your epidural hematoma, and when you give epidural hematoma, what will happen? The brain will shrink and the epidural hematoma size will increase. So why you want to give mannitol in an epidural hematoma? What is the indication for mannitol?
Mannitol usually we give only if there is any impending herniation or any signs of raised.
So already that is causing an impending herniation. So you need to give mannitol. So whenever you have a doubt in mind, when there is herniation, there is no other option that you have. You have to give mannitol. So this edema decreasing, bleed increasing, because already it has led to a complication. So there is no point in waiting further. So you have to give mannitol. Mannitol is only indicated. So why that is said is that generally when you just see a head injury, there is a practice to give mannitol. So that to be avoided. So when you are just seeing a head injury, patient is otherwise GCS is full and is stable in the ER, and you are seeing an epidural hematoma and somebody is coming and writing mannitol which is not indicated. So that time it might be a concern. But when you are really wanted to indicate it to give mannitol, that's not an issue. So that is regarding mannitol. In this patient, I will preferably not give any mannitol. 3% saline agreeable, but not mannitol. Seizure prophylaxis?
Seizure prophylaxis we can start if only there is
for this patient. My question is for this patient.
No need to start.
I think yes, you need to start. It's a larger subdural hematoma and it's a bilateral subdural hematoma. You need to start him on seizure prophylaxis. So subdural, epidural, but no need to continue. After 1 week of time, you can stop it. But you imagine a subdural hematoma this larger size, you should not wait. Again, the reason being his risk of seizure is being high because of a chronic alcoholic, and he can start developing anytime alcohol withdrawal seizures also. So seizure risk is high. So definitely yes, you need to start. I will say you have a patient with depressed skull fracture, any GCS drop is there from the baseline, any epidural or subdural hematoma, it is preferable to start on a seizure prophylaxis. Phenytoin, levetiracetam, whichever drug that you are comfortable with, you need to start on seizure prophylaxis, but no need to continue after a week's time. You can stop. But definitely you had witnessing a seizure, there is no point in asking this question. But this patient, yes, we should start a seizure prophylaxis. Okay, so tranexamic acid role.
Tranexamic acid, only a few limited studies have shown.
What is the limited study role? What is the limited study that, because that is very important study as per for an emergency physician. So this is the CRASH 3 trial. So CRASH 1, CRASH 2, CRASH 3. CRASH 2 trial is what we started giving tranexamic acid for hemorrhagic shock. So CRASH 1 was steroids for head injury. CRASH 2 is for, that's what I said, tranexamic acid for your hemorrhagic shock. And CRASH 3 is basically tranexamic acid for isolated head injuries. So it is not very effective. They have not found out any usefulness, but the final result I think it's yet to come, because I am not aware, because we had enrolled for CRASH 3 trial long back. So we haven't received any update whether CRASH 3 trial, to my knowledge, there is no much use of giving tranexamic acid. Even role of tranexamic acid is only proven in hemorrhagic shock. Even in upper GI bleed, it is not proven. So there are some centers they used to give this tranexamic acid for upper GI bleed, which is of no use. So that is tranexamic acid for you. So, and when you wanted to intubate this patient,
We'll have to intubate if in time Jesus less than or equal to 8.
less than or equal to 8, I will not
if they-
agree. I will not agree. For this patient, less than 8 GCS means he's already gone. He's already gone. Less than 8. You are seeing,
Already dropped
because
in
already 15 GCS and he's going for an 8 GCS, you are waiting for intubation. That is not correct. This group of patient, I think you should go ahead with 12 GCS. So whenever you have head injury victims, it is already preferable to go for a GCS. Like whenever it has come to moderate to severe, that range, 12 GCS, less than 12 GCS drop, it is better to go ahead and secure the airway. Why we are intubating? Why we are intubating?
If a patient has any vomiting episodes or
See, the problem, what is the reason behind intubation for head injury victims?
one is this protection of airway.
Okay,
If he has
agreed.
any vomiting episodes or any secretions and his sensorium is low, he will not be able to swallow. So he'll aspirate. And second one is to adjust our PCO to any hyperventilation.
For hyperventilation, I don't want to intubate, man. That's not needed for hyper. Why you want? Seizure, okay. Then, see, you imagine a GCS 12 patient, he's having a head injury. What is the criteria? It is a moderate to severe head injury. So, he's having this head injury and he's trying to maintain his airway. The body is trying to maintain his airway, okay. So, already the body's some metabolism is being utilized to maintain the airway. So, why can't we divert towards the prevention of brain injury? So that is a question. You understood? Already our body is trying to protect the airway. Same thing what I said in hemorrhagic shock also. You can early intubate the patient. There is no problem. It's not just if at all the patient is conscious oriented, he's having significant hypotension, you can go ahead and take care of the A. So that is one thing. And majority of this group of patient, maybe 12, they will be agitated sometime between. And that is again worsening the head injury. So you're going to worsen the head injury. So that should be avoided. So for that reason, there is always justifiable. So you have now a lot of oral bleed. He is aspirating, head injury, a lot of oral bleeds. But GCS is not 8. So don't wait till 8. You can early intubate. Maybe 12, 10 also, that is fine. 12 is some guidelines. Even 10 is also, it is okay. So a little bit of early intubation is warranted in this group of patient with head injury. So again, when you want to do RSI, what are the drugs? Because these questions I am asking you, what are the drugs that you wanted to use?
Yeah, we mostly we can use etomidate or propofol. A propofol we are using, we'll have to check for the hemodynamics also.
Okay, so again in isolated head injury, the problem here, hemodynamics. Any condition when you are taking for RSI, hemodynamics is the concern. And here is a situation where we don't want any compromise on hemodynamics. We don't want any compromise. So if at all any compromise is happening, that is going to affect your cerebral perfusion. So you want to select an agent where hemodynamics is least affected. So least affected one is etomidate, agreeable etomidate. Why not ketamine? Why not ketamine? You said propofol. I'll say ketamine with propofol. Half of ketamine with propofol. Why not ketamine? Why you didn't say regarding ketamine?
Ketamine, because in some studies,
traditionally when you learned regarding ketamine, it was supposed to be said it should not be used in raised ICP. So that is a traditional thing. But when you are having a patient with hypotension, remember when you are having a patient with hypotension with head injury, and you are going to use an agent which can cause hypotension like propofol, it is better to go ahead with ketamine. So there is no contraindication as such. When you go through the literature right now, there is no contraindication for the usage of ketamine. But already the blood pressure is somewhere like 200 over 100, 180 over 100. Then you don't use ketamine. So that is it's like 110 over 70. You're safe to use ketamine. So the ketamine, it will increase the heart rate, it will increase the blood pressure also. So maybe in those situations, 130, 80, you want to use propofol with ketamine. So what is the advantage of propofol?
No, propofol, if it reduces the pressure, ketamine will increase the pressure. So we can
Okay, why you wanted to use propofol? Propofol has got a very good property. Anti-seizure property. It has got an anti-seizure properties also. So anti-seizure property with a drug which can stabilize hemodynamics. So always we can give etomidate left and right for all patients that comes to the ED. But you should know what is the ideal situation. to be used. So when you can use ketamine, where all you can use ketamine. What are the, see this condition I will not go for any other agent. I want ketamine only. One condition, can you tell me? Acute exacerbation of COPD and bronchial asthma, where it will help. One condition I want to give propofol only. This is the best drug for this patient. One condition you can tell. Status epilepticus. You are going to intubate status epilepticus. Status epilepticus is a drug of choice. So again, etomidate anywhere you can use. So etomidate, even traditionally they say it can cause adrenal insufficiency, adrenal suppression. So 100 microgram can cause minor suppression. 20 milligram can cause minor suppression only. It is not very significant suppression. So you can give 100 mg hydrocortisone, that is sorted out. Okay, so etomidate, the problems with etomidate, 2-3 problems. What are the major problems that we are not seeing here? Why we are not seeing here is because we are already pre-medicating them with either with fentanyl or with midazolam. The only problem when you are using etomidate alone is myoclonus. Myoclonus is one issue, and pain at the injection site. So when you are sedating a patient and you are giving the injection, you never know these things. So majority of the time when you are using it with fentanyl or midazolam, you won't see myoclonus. When you again look into the literature with etomidate, so that is a one traditional complication that they have said regarding etomidate. And etomidate, due to this property of adrenal suppression, rarely it can be used for the management of pheochromocytoma also, for infusion. So you have a patient who have got refractory pheochromocytoma. We have used for a patient, that's the reason why I am telling. He is getting ready for the surgery. His blood pressure is not getting controlled. Tomorrow is surgery. Whatever the drugs that you are getting is not getting controlled. So we started him on an etomidate infusion and that patient responded. So that is the usage of etomidate. Very rare usage. I'm just like one side effect. It can be used as a potential effect for another disease also. So we had regarding the airway management we have discussed. Then what are the drugs that use? Paralytic agent rocuronium is the safest. Even succinylcholine, there is no contraindication. But the problem, what are the problems with succinylcholine? We are not using succinylcholine. What are the problems that you will see with succinylcholine? Hyperkalemia. So where you don't want to give, I will not give succinylcholine for this patient.
Some patients with hepatic metabolism, prolonged metabolism, succinylcholine patients like
Burns
That
patients.
Burns patient, when the Burns patient has come directly in front of you, you will not use succinylcholine. Immediately it will not cause hyperkalemia. See, Burns patient, after 3-4 days, they are having higher risk of developing rhabdomyolysis. Then only they will have developing hyperkalemia. So after 4 days, if the patient is coming, only we are not supposed to use succinylcholine, not immediately. Then what is the other problem with succinylcholine?
Malignant hyperthermia.
Malignant hyperthermia. So what is the drug that you should be available with you? Dantrolene sodium. It is hardly available. It is very limitedly available only. So dantrolene sodium is the one drug that you need to. And what is the other problem with succinylcholine?
apnea.
It can cause apnea. What will happen to the esophageal sphincter? See, the problem is you are doing back mask ventilation. So this is the problem that when we were using succinylcholine during that time, when we are doing back mask ventilation. So there can be a lot of gaseous distension. And suddenly you are giving a succinylcholine. What will happen to the sphincter? Sphincter will relax. Suppose you are not intubating on your first attempt, and again you are accidentally intubated somewhere else, the patient 100% will aspirate because of the sphincter relaxation. So that we are not seeing with rocuronium much. We are not seeing with rocuronium much. So that is the reason why we prefer to use rocuronium and instead of succinylcholine. So succinylcholine can be, it's a very good drug. I am not saying it's not a bad drug, but in the ED, it's always when you look at the ATLS guidelines, they prefer to use rocuronium. And what is the antidote for rocuronium? That should be available with you in the ED. What is the reversal agent? It is Sugamadex. So that is the reversal agent. Sugamadex is the reversal agent that should be available. So let's come back to this patient. So we are coming back to the patient. So we have started all this effort. So when this patient should be, you said by looking at the CT itself, it is an indication for a surgical intervention. So when you will see, okay, you don't have a neurosurgeon in your center, I want to refer this to a neurosurgeon. So when you will say that?
Based on clinical features and imaging features, we can divide. In clinical features wise, we'll have to check for any GCS drop, or you have to check for any any ipsilateral fixed dilated pupil or any asymmetry of the pupil.
Okay.
Then we'll have to
CT image wise?
CT image wise, thickness is more than 10 millimeter, or if the midline shift is more than 5 millimeter, or if there is any brainstem compression, or in hydrocephalus developing.
You need to immediately evacuate. Now, what are the surgical options? Whether it's a burr hole evacuation or whether it's a decompression. So, what do you wanted? So,
it
for
is
this
a-
patient, for this patient,
For this patient, we can
what are they planning to do with him?
they did a burr hole evacuation.
They did a
bilateral burr hole.
bilateral burr hole evacuation. So, when you wanted a decompression,
If it is
it's a pretty large hematoma and there is a chance of rebleeding. Okay, you have to understand he's not on any antiplatelets, he's not any anticoagulant. So you have to benefit risk versus benefit, which is better, and it's a larger one, and you need to evacuate. Acute and chronic components are there. So it's an acute component, the blood will come out, but it's a chronic component, the blood might not come out. So that situation, it might be challenging. So already on antiplatelets, chance of rebleeding is very high. So they might go in for a decompression. Since he is preserved completely, they would have gone for a burr hole evacuation. Okay, so you have anything else to add on?
the brain herniations.
Brain herniation, you have 4 brain herniation syndrome. Angle, tonsillar, then central herniation.
Transcendoral, cerebellar.
Clinical differentiation.
If there is uncle transcendoral, then there will be fixed dilated pupil. If there is fixed dilated pupil, if it is central, there will be restore for it will be pinpoint pupils. Differentiating them, if it is central, then there will be hypertonic features and this Babinski sign
Positive.
decorticate posturing. If there is any cerebellar, tonsillar, if it is there, then there will be flaccid paralysis with the pinpoint pupil. Then there can be posterior fossa involvement. It will involve that gaze
palsy.
Gaze palsy.
Okay. Fine. So, in a nutshell, what we have to say, we have discussed regarding diplopia, cause of diplopia in ED, headache with diplopia, and then we went ahead with subdural hematoma discussion. It's our responsibility, do no further harm. That is the responsibility of every doctor. I'm not saying do no further harm by causing hypoxia, by causing hypotension, by causing hypoglycemia or hyperglycemia, and causing hyperpyrexia, which is more significant. So we need to prevent secondary brain damage and use our drugs judiciously. Where to give seizure prophylaxis, where to start 3% saline, where to start mannitol. That is our description. Okay, fine. Thank you.